Black Doctors, hosted by the Caribbean and African Health Network. Ever sat in a doctor's office thinking, they just don't get it? Or search for health advice online, but you can't understand it? Felt unheard? You're not alone, and you found your solution with Health Hour. Every Saturday at 11 a.m., this is your space where Caribbean and African healthcare professionals speak about health with a focus on Black people. We tackle the topics that keep you up at night: mental health, chronic conditions, preventive care, sexual health, men's health, women's health, heart disease, and much more. All with the cultural context that matters, because our Black doctors understand the unique challenges we face. Here is what you can expect: real talk from doctors who look like you and get it, lived experience testimonies, practical advice, illness prevention and management tips, and a space of understanding without judgment. You also get to ask questions. Your questions drive the conversation. Health Hour, where community meets Black health expertise.
Hey, not
Good
now.
morning. Good morning, everybody, and welcome to the Health Hour. Hi, everybody. My name is Kemi Adewumi, and I'm a GP trainee in Manchester. I just want to welcome everybody from wherever you are joining us and on whatever platform. It'd be great if you could put in into the chat box where you're joining from, what city you're in, what country you're in. It'd be great to find out where everyone's from. So welcome to the Health Hour, which is an initiative run by Khan, and it's an opportunity to get empowered, get information from medical experts within our community. And today we have a great topic on the sickle cell breakthrough. And we're going to have this topic done by our speaker, Mr. Dr. Mohammed Kamara, who is an emergency medicine consultant, and he's got over 35 years of experience working within medicine. Additionally, he's also the Senior Independent Director at the Caribbean and African Health Network. So he provides oversight and supports strong governance within the CAR network here. So I just want to remind us all that during this talk, the chat's going to be open, so you can put any questions, any comments that you'd like to ask or just contribute into the chat. The chat's going to be monitored, and at the end of the talk, we'll be having a Q&A session where all the questions will be asked with Dr. Kamara, and I'm sure we'll get amazing answers from that, just to clarify anything. So without further ado, I'm going to hand over to Dr. Mr. Mohammed Kamara on our talk on sickle cell breakthrough. So welcome, Dr. Kamara.
Hey, thank you so much for having me. I am hoping that we will be able to go through some issues related to sickle cell. And I don't want to be teaching my grandparents to suck eggs. But this is a topic that is very close to my heart. So when I was asked to do it, I felt the need to probably find out what people know about sickle cell. So I hope I would have people to interact with me. And I always start with icebreakers. This is the first one. Who identified or discovered sickle cell disease? Does anybody know in the audience? I can't see you, so maybe you can read for me, Kemi, or maybe someone can talk. I don't know. The reason why this is the first icebreaker is because there is a misconception in terms of who founded it. And I think it's important to clarify, or to probably able to establish the fact that sickle cell was found or discovered by a countryman of mine. I'm proud to say that. He's no less a person than James Africanus Beale Horton. He wrote about this condition in his book, The Diseases of Tropical Climates and Their Treatment, which was in 1874. If you were to Google it, you'll find they will tell you about James Herrick, who they say was the founder in 1910. So you can see the discrepancy there. And if you don't believe me, take a look at this. Just outside of the University of Edinburgh, in honor of the first African graduate, 1835 to 1883. As you can see, he was born in Sierra Leone of Igbo. I think the Nigerians would understand that. So the Igbo recaptive slave, son of a recaptive slave who provided one of the earliest descriptions of the sickle cell disease. And on the right there, you can see that in 1910, this gentleman, this scholar or whoever you call him, James Herrick, added to that, but you wouldn't get to hear that. And of course, top of that all, on the title there, you can see the World Health Organization decided to declare the 19th of June annually as the World Sickle Cell Day. So it tells you how important it is to everywhere in the world, because sickle cell is not just sort of assigned, if you like, or maybe found or maybe diagnosed in the people of color, Black and Caribbean or Black minority ethnic. It's now a global illness. Yeah, you'll find out why. Anyway, I always like to start by defining. If you look there on your right, this is when you cut the blood cell, the red blood cell. The sickle cell is a disorder of the blood, and it's inherited rather than it being contagious. So if it's passed from one person to another, it's through the genes rather than by contact or by eating or sneezing or coughing. No, definitely not. But if you look at the normal red blood cell in the blood vessel, you can see that's when it's cut. You see it's round and it's got that middle. Then the sickle, that's why it's called sickle, shaped like a sickle. This is an instrument they use to harvest rice. If you saw from my titular page, you'd see the instrument I'm talking about. I'll show it again. There you go. On the right there, that's the sickle. That's what they use to obviously harvest the rice. Okay, so you can see that when it becomes something like that, like this, then obviously it becomes fragile and it can easily clump up the blood vessels through which it flows and cause problems for it. But when it's round like it is up here, clearly you can see it flows smoothly. So, second icebreaker. Say, only people of African ancestry can have sickle cell. That's not true. As I said, it's now become a global illness. It's actually found in the Americas, the Indian Ocean, definitely most of the people of African ancestry. However, it's around the world, like I said. So, genetic blood disorder, where the red cells are shaped like a crescent, that's a sickle, instead of it being round or they being round. Obviously, it causes problems of the flow and therefore can cause obstruction and therefore leading to crises. And those crises we'll talk about as we go along. So you can see the facts are that, as I said already, it's not contagious. It's inherited, and obviously it's commonly seen in Africa, the Caribbean, Indian Ocean, and of course the Middle East nowadays. But believe you me, it's also in the Americas, both North and South. And of course, one thing that we need to understand is that early testing can save lives. There's no questions about that. Symptoms, as we said already, you can see for yourselves, but we'll talk more about that as we go into the talk or we progress. So, a bit of the epidemiology. 5% of the world population, and we know the world has 8 billion, maybe getting longer or higher. As we go longer into life, there's definitely more of this to be, what's the word for it, to be revealed, as it were. So 300,000 of children born each year are born with this hemoglobinopathy. Now, people that know English will tell you about prefixes and suffixes. Now, the PATHY is a suffix, which means there's something that is unwell, it's poorly. So heme is blood, globin is a protein. So a hemoglobinopathy, which is the blood cell, which is a protein that is unwell. So 300,000 people, children are born with that annually. And then, of course, in Africa, those that are born with the disease, there's a difference, 200,000. So it's, although it's 100,000 between, but those who are born with it does not mean they have the disease. So you'll find that as we go. And you can see sub-Saharan, they say Ghana, Nigeria, Uganda, but as I say, again, it depends on migration and what's happening, intermarriages and all that, hybrids and all that. Yeah. So as you can see, beautiful picture on the left there. As you can see here, this streak is where it's prolific. So 20 million people worldwide. And of course, in the UK, we have about 15,000. And those that have the illness and those that carry the trait are 300,000 people. In the US, about 100,000. And of course, we know, as we said already, the highest prevalence is in West and Central Africa. But again, emphasizes the fact that it is now global rather than just being sectional or regional. It again emphasizes that. It's just a picture of that. It's changed the landscape, the paradigm shift. You find it in Turkey, Greece, and Italy nowadays, as well as in Saudi Arabia, as you can see. Yeah. And one thing that people sometimes maybe fail to observe is that wherever you have the sickle cell allele, that is the gene, it's very likely you have malaria. Yeah. So if you look at it, there's a very close similarity of the two maps, the one on the left and the one on the right. Most of the people who have hemoglobin C, which is one of the risk factors of giving birth to somebody with the trait or somebody with the disease, are found to be resistant to malaria. But there's this distinction, and there's a connection between the two. Oh, why are we hit the hardest? Our communities are hit the hardest. Well, of course, because we carry higher rates in the communities that we are. So, and of course, a lot of people would think, well, when we had HIV and all that, clearly there was a problem. We were most affected because of what? Historical underfunding. And of course, the lack of awareness, which is why we're doing what we're doing, to create the awareness, to sensitize, to educate, to energize our people. And of course, if this chronic underfunding and lack of awareness, that causes delays in the diagnoses. And of course, with that comes unequal access to care. Here's also this big problem, cultural stigma around genetic conditions. People think that, oh, hang on, if you're not a prayerful person, if you're a bad person, if you're a wicked person, you definitely get these illnesses, diseases, which is completely untrue. It's got nothing to do with how fervent you are, how pious you are. Illness can befall anybody, as we found recently. The ones that you think are untouchable have come out and said they've got cancer, and you wouldn't have thought that would be possible. But yeah, it is there. It's an illness, and it befalls anybody. It's indiscriminate of your color, your creed, your descent, your age, your religious and political activities or orientation. Yeah. So, but with that, and with your contributions and generosity, treatments are changing. There are new ones that have been developed within the last 2 or 3 years. We'll find out as we go. But the key thing here is awareness. We need to be aware. that indeed there's new treatment. Indeed, this is not coming from the gods that are angry with you. Indeed, it happens to anybody, whether you're black, white, or in between. Definitely, you can befall illness. So, but we are worst affected because of the lack of the awareness, the underfunding historically, and of course, the health inequalities that we face in terms of access to care. So, icebreaker 3 is contagious. Well, we dealt with that already. Definitely doesn't pass from person to person. It is inherited, and so therefore it passes from one generation to another, i.e. from the parents to the children, grandparents to the children, and things like that. This is a slide of the talk. Now, I don't know how long I'm going to take on this, but I want you to focus on this. You look there, there's 5 squares. So the one on the left is when you have one parent having the trait. You go red, pink, gray. Red symbolizes the disease or the illness. The pink is, did I say red? Yeah, the red is definitely the person that has got the illness. The pink is where the person has got the trait, and the gray is when the person is normal. So if you look, it was specifically designed. If you look in the middle here, there's no escape because both of them, i.e. the mother and the father, they both got the illness. So for every pregnancy, I repeat, not all the children, and I need this to be clear, every pregnancy, there is a very high chance of the child or the offspring or the issue being a sickler. I hope that's clear. It doesn't mean if you have 10 children. No, this is every pregnancy. There's always 100% possibility. So these are the ones that need to be really, really counseled, take into consideration what to do and how to proceed further. You look there on the top, you will see the dad has got the trait, but the mom is not got the trait and has not got the illness. And with them, you have a 50-50 chance for every pregnancy for the child to be one that has the trait, and obviously the other 50% is that they would be born without it. Going forward onto your right, here you are, you've got both of them, both parents having the trait. And with them, with every pregnancy, there's a 25% chance of having a normal child. There is a 25% chance of having a child with full-blown sickle cell, and there's a 50% chance of a child having the trait. And then move forward to the one on the bottom right, you can see that where there is one parent being a sickler and the other one is a carrier, and what you have is a split in the middle. There's no normal child to emerge from this relationship. What you would have is 50% chance of children or a child with a trait, and of course 50% that they are full-blown sickle cell patients. Moving right here to the left, where you have one parent full-blown. Here on the right is full-blown and a trait. Here you have full-blown and normal. What you have is 100% possibility of the trait carriers. And then last but by no means least, you can see here, you can see there's a 50% that we talked about of every pregnancy of either being a trait carrier or definitely normal. I hope this is clear. If we have to go through it again, I don't have a problem with that, but this is the slide of the talk. So, icebreaker number 4. Well, people believe there's only one sickle cell disease or one type. I can tell you that's not the case. There's a few. There is the HBSS. So, by the way, HB is hemoglobin. So the SS, people know it, SS, SC, and of course, thalassemia, major, minor. These are all the different types. As you can see, on the right here, you can see SS, SC, thalassemia, and you've got the other 3, SD, SE, and SO. And they're all different types. And the only way you can get them is by inheriting them from mommy and daddy. That brings us to this. This is very important. See, sickle cell, like, other illnesses, like we call them the SCDs and NCDs, we call them. You can see it affects major aspects of the human body, almost everywhere. It starts from the head to probably the toes or the digits, if you like. So symptoms that people can present with are fatigue, and we know why that is because of the chronic anemia. Incidentally, you should know that the lifespan of a red blood cell is 120 days. So that's the normal one. When it's shaped like the sickle cell, red blood cell, obviously it lasts less than that. So in effect, for you as a normal person, i.e., inverted commas, to change your blood probably 3 times a year, for the sickler, they might need to double that. And so obviously they would always be underfilled. If you're looking at the tank of a motor car or whatever engine you drive, you get fatigue with that because the heart is pumping more than it should, it's working more than it should, and so therefore with that you get fatigue. The blood is not carried to the areas where it's needed, and therefore you get fatigued easily. Now you can present with the pain, which is symbolic or indicative of crises. I don't know how many people know the types. So there's vasoocclusion, vaso, which means vas is it's like a blood vessel, or it could be like a tube. And occlusion, obviously, because, like I said, it clumps up because it's shaped like a sickle, and so it obstructs the blood flow. So therefore, the lack of blood flow would cause problems with circulation, and hence you can get crises with that. It could lead to destruction, as we said already, and with that, there is anemia, and that is typical of what we find, and it is jaundice that normally sometimes sets you off. So what we have with the vasoocclusion is mainly triggered by stress, some infections, and the hemolytic crisis is more to do with obviously starvation, dehydration, and other things like that, and so, some other infections as well. They can obviously cause hemolysis, and therefore that can cause problems. There is the third one, which is splenic sequestration. As you can see, it's on the spleen on the left there. Yeah, the spleen. This is the liver on the right, and that's the spleen. Now the spleen become atrophied. It can die on its own. Yeah, or it can actually get really enlarged. So if you have a little one, this is normally in the little children, where they have a swollen belly and they're known to have sickle cell, and they're tender on the right, on the left where the spleen is, then clearly you need to think about that, because there's a lot of blood cells that can die in there, and sequestration, and sometimes it can cause the catastrophe, which can cause emergencies. There's no questions about that. So that's one thing to think about. It can either die on its own, which is infarction, or it is called autosplenectomy, whereby it becomes defunct. It doesn't work anymore. And such people, as we know, when they remove the spleen, you then need to be on antibiotics forever on a daily basis. That is something that we'll have to talk about later. Aplastic is obviously when it doesn't grow. And so obviously, because of that, there's always a problem with the bone marrow, and that can be a result of the attack of the sickle cell shaped blood cells. So it could be dactylitis, as we said already. It can affect the digits of the hands or the feet, and they can be swollen, inflamed. I think I have a picture of it, painful, and obviously that can lead to arthritis, as it were. It also can be afflicted with bacterial infections and any other fungal or viral infections. We talked about jaundice already. Obviously, if you have increase in the demolition of the red cells, you definitely get the liver to be overworked and it can't cope. And so therefore, one of the signs of failure of the liver to cope is obviously jaundice. You can see that, and sometimes can be difficult to find in the black person or the person of color. Yeah, you can be prone to lung infections. Of course, there's cardiac problems because the heart is beating too fast, it's working over time. It comes to a point where it says, I'm getting tired and need help. And that's when you begin to experience the symptoms of heart failure. And of course, if you have circulation problems in the lower limbs, which is very likely, then you can end up with trophic ulcers, they call them. Yeah, it's not just with diabetes or someone with vascular compromise. You can have that with sickle cell. And of course, the bones can die, typically on the shoulder and of course on the hip. It's what we call avascular necrosis, AVN. Typically, they present with pain, difficulties walking, probably innocuous trauma, very mild trauma, or maybe just walking or something. They feel the pain because the blood supply is compromised. This is mainly why you get the crisis. So if the blood supply to the bone in the hip, which is in the head, is compromised, it can start dying. And when it dies, we call that avascular necrosis. And avascular necrosis can lead to fractures. Yeah, and the infarct can lead to fractures, pathological. You can get retinal detachment, retinopathy, and of course, it causes stunted growth. Yeah, people used to think that the ones with sickle cell don't live long. Well, we found out that's not the case. I have said so much. I think you need a break, or I need one. Listen to the video.
Hello, Dr. Kamara. We can't hear the sound of the video.
You can't hear it. All right. Well, I'll probably try and play it next after the end of it, because I need to go back to probably share, if you like, a screen or something, and the sound. Yeah. Anyway, antenatal screening, which is important as we were, it's important. I couldn't overemphasize that. This is important because you need prenatal diagnosis before birth. There's no questions about that. They can use the villus sampling, or they can do amniocentesis. Now, amniocentesis can be obviously dangerous. Sometimes it can cause problems with prematurity and things, and sometimes labor that is not scheduled. So we need to compare the risks versus the benefits and see how best to do that. But the way they do it, they offer it. The blood is sent, that test is actually offered, and the blood is taken and sent to the laboratory for the hemoglobinopathy that we said, because they're screening for it. If you get a negative result, then that's it. You go no further. If you get a positive result, then obviously what you have then is you then have information and counseling that is offered to you as parents. And that then leads to partner screening. So, for example, if you, as the mother or the pregnant mother, expectant mother, has got that a trait, and then of course we don't know about the partner, then they have to screen the partner. Again, they send the blood, and if there's negative result of the partner, then it goes no further, and that would be that. But then if there is the unfortunate situation where there is a positive result, then of course there is a risk of the offspring having one of the three outcomes, as you know already. Then of course they can test the mother's and the child's just the mother's obviously, but then mainly is the child, because it's more a concern for the child that is coming into this world. So they'll check that, and then if at all the child is unaffected, then that's that. Take no further action. But if the child or the baby is affected, then obviously you need information and more counseling, and then you'll be offered the choice either to carry on with the pregnancy or to think about, consider strongly, terminating the pregnancy, which unfortunately is sometimes one thing that could happen. However, it doesn't mean that is the end of it. There's other ways of dealing with things, but this is a distinct possibility. Okay, so this is just emphasizing that there is a sickle prep, which is what they use to perform that test to see what is happening, whether indeed this is sickle cell anemia, and if it is, what type it is. And then the other one obviously is electrophoresis of the hemoglobin, which would give you the SS or SC or the thalassemia. So, as you can see, I did mention that it can affect the digits of the hand, of the feet, as you can see. See, it's quite red, shiny, swollen, inflamed, and very painful. Yeah. So, and of course, if it's not treated in time, then probably infarction can happen, i.e., the bone can die, as we said already, because of the occlusion. As if you know this, then you would see that when the babies are just born, they sort of have some relative immunity until they get to the point where they achieve or they reach to 6 months and to 2 years. So 6 months to 2 years, maybe 24, 6 to 24 months, then definitely this can happen. You can see the difference between the normal and the abnormal. It's very, very obvious. I think you all can see it. So when that happens, what they will need is obviously painkillers, definitely, because it's very painful. And of course, they need to be hydrated. And if needs be, sometimes they might need antibiotics. But that's the kind of thing you can get. So in children, yeah, what you get are the signs and the symptoms of anemia. So they present with different syndromes and different symptoms and signs. And you can see there is the chest syndrome, breathing problems, pain. They can definitely spike a temperature or a fever. And what they will need is probably antibiotics. Sometimes if the hemoglobin is very low, and of course they're struggling to maintain their saturations because that is worsened by the low level of hemoglobin, then they might warrant blood transfusions. Yeah, they need analgesia. Of that, you have to be really cruel not to offer that. And of course, oxygen helps because is of the fact that the oxygen levels are low, and if they're low, then clearly the organs will suffer. Anemia we talked about already. They're pale. It's very difficult sometimes to establish that in a person of color, but if you pull the eyelid, the lower eyelid, you can definitely see the pallor. And sometimes under the tongue, you can see that, as well as you can actually observe jaundice. They get tired easily. Obviously, with that, they hyperventilate, they get problems breathing. And of course, as I said already earlier, stunted growth. Puberty is later than usual. And of course, it depends on the symptoms. The treatment might include antibiotics and blood transfusion. Hand-foot syndrome, we said that already. The affected digits are cold to touch, they're swollen, they're painful, and they can have fever with them. The ones that deal with children can recommend analgesia and fluids and sometimes antibiotics. Infections we talked about already. It's important to remember that vaccines are very, very have got a very important role to play in this, because with vaccines, some of the infections can be warded off, can be stalled, and of course the recurrence or the, if you like, relapsing episodes can be stalled. In so doing, the child can have relative episodes of longer lasting periods of normality. So, yeah, pain we talked about already. The splenic crisis. Now, this is important that, as I said that, yeah, sequestration. Yeah, so on the left, the baby's belly or the child's belly is swollen and it's definitely painful. Then they're weak and their heart rate is definitely fast. Then, yeah, you got to think about that and you got to take them to the hospital where they will require treatment and if needs be surgery, as well as transfusion of blood. Believe it or not, I've had a 5-year-old who had a stroke because of the fact that nobody could pick out the fact that they were sicklers. So if you have a child who's reporting or complaining of severe headache, weakness to one side, and not being alert as they are normally, impacting their speech, so it's slurred or they can't speak, and the vision or the hearing is impaired, then think about that. And the sooner you get them to the appropriate institutions of care, the better it is for them, the outlook. Vision, we talked about retinal detachment and of course retinopathy. again, pathy, that suffix, may well be something that needs to be looked at regularly, monitored, surveillanced, and if needs be, surgery to prevent further damage to the retina or loss of vision. So we go a bit forward. The adolescents, the preteens and the teens, they also have the acute crises, mostly the vaso-occlusive ones, the ones where the blood doesn't flow into the blood vessel. This is a typical one. They are an elite group, the acute chest syndrome, which is a leading cause of death in sickle cell and is characterized by abnormal chest x-rays, pain, fever, anemia, and of course, there's infection as well. And because the immune system can be challenged, they might end up having complications and might lead to death, unfortunately. The other concerns are the strokes that we talked about, either they're silent or overt, the organ damage, and of course, the increased risk of infection. Leg ulcers, we talked about already. It's very prevalent in this age group, and aseptic necrosis, which is AVN, and we talked about it already, the hip and the shoulder. Retinopathy, the eye damage, talked about already. This is the fifth one, and I think it's the last one, the icebreakers. People think it's short term. Well, it's not short term. People used to think, or we all believed, that they have to live with that for the rest of their lives. But of course, since 2023, 24, there's been a breakthrough, and we'll talk about that. So, treatments available, as you can see. I mentioned the vaccines. It's absolutely vital to ward off flu or influenza, meningitis, and pneumonia. Those three definitely should be taken routinely, as it were. So we should be urging our children to be at the head of the queue to get these vaccines done. Folic acid is important because it helps with the blood formation, blood transfusion as and when required. And now we have stem cell transplant. This is now gaining momentum. And the mainstay of the treatment, as you can see, is analgesia. I cannot stress this enough, because people come to us and in the ED, and most of the time they sit there and people don't cotton on or, understand that, look, these people are in pain. So they need analgesia, and it's not just a simple one, it's a strong one. And this is why most of the people who suffer with crises, they prefer to be taken from their homes to the emergency department via ambulances rather than going there on their own. They would prefer they take their cocodamol at home and then wait, just grin and bear it until the ambulance comes, because they know when the ambulance comes, they probably can get morphine, they can get fluids, they can get paracetamol in the vein. And that is far better than sitting in the waiting room when the medics there or the personnel there look at them and say, they're just feigning it, they're just this and that. It's absolutely appalling when sometimes I actually get to have words with my colleagues in terms of a lack of knowledge and what to do, and in terms of the fact that, look, you need to be prioritizing these patients. Yeah, they come here for a reason, and that reason needs to be fixed before it takes, control of them. So morphine, hydromorphone, definitely you need. Ketorolac is an anti-inflammatory medication, which is also helpful. And of course, antibiotics as and when you need them. It is hydroxyurea. Those who are sicklers would have heard of this. Definitely. Hydroxyurea is very important. It's useful for long-term purposes. Erythropoietin is helpful because it triggers or generates the production of red cells, which is good because of the anemia. Niprosan, people will say herbal products. I don't know. I can't swear by that. Some people will probably say it's good. Yeah, there's evidence which is very conflicting in terms of the efficacy of magnesium. There's also the antifungal medications, clotrimazole, which I'm not sure, but if you have a fungal infection, antifungal is probably logically the right thing to do. And of course, hematopoietic cell transplantation. Now, this is important. The use of it is limited, but I think it's gaining momentum. We'll get to find out as we go into the talk towards the end. Gene therapy has also been found to be curative in some aspects of it. Bone marrow transplant is absolutely effective, but it requires a matched donor. So here we are. This is lightning learning for everybody. If you look at it, stop, look, and learn. The crisis occurs when the small vessels are blocked, leading to ischemia, so the lack of blood supply. The end organs become damaged, and of course, the pain. So if you miss it, it can lead to complications like disabilities, and as I said, unfortunately, sometimes death. So precipitating factors, you have infection, low oxygen. It could be because of an infection in the chest, or it could be because of other illnesses, like people might have asthma, might have COPD on board, and that doesn't help. Stress, lack of appropriate hours of sleep, cold weather. So when the weather changes, like it's doing a yo-yo up and down, be careful, be mindful, because you are vulnerable. And of course, there's certain medications, if you take them, they could actually precipitate that crisis. So as I said already, abdominal crises, you have the acute chest syndrome, you've got strokes, we talk about vascular necrosis of the bones, and this sometimes people don't know about, the priapism, where they have this erection that is not remediable in the male. And so this is an emergency, and that needs to be dealt with in a urological institution, i.e. the urologists are the ones to deal with this on an urgent basis. A plastic crisis, which is mainly caused by this powerful virus, is B19, virus B19 infection, which leads to life-threatening drop in the hemoglobin. So it leads to a plastic crisis, and so therefore transfusion has to be given priority in this. So when you have them, when they come to us, what we do, we slap on the non-rebreathe mask, 15 liters of oxygen. It helps, because if they're hypoxic, then the tissues are definitely struggling. So the oxygen will help to deliver the oxygen via the blood. Analgesia, as I said already, absolutely vital. Morphine, preferably, rather than anything else. And it's not just giving it, but you need to reassess the efficacy. How effective has it been? How good has it been? Is it less or not? Do we need to try something else because they're in tremendous pain? Yeah. And of course, we need to follow the individualized plans, the bespoke plans. This is what us as medics in the ED don't do. As I said, that's why they prefer to come with an ambulance rather than come to the waiting room where they walk in. Yeah. Transfuse the symptomatic, anemic, and of course, involve hematology, because sometimes they have a retic count. They call it reticulocyte count. And you can see we have references there from NICE. So the breakthrough that we have, treatments, from 2024 to currently, we have the gene editing cure, which is CRISPR based. So it was first approved in the UK and the US in 2023. It's used to switch on the fetal, that is the baby's hemoglobin, preventing the sickling effect, so the clumping. Yeah, the early results, some people have reported, most patients have become crisis-free because of that. And the second one, obviously, the non-CRISPR, which is the gene. So the first one was gene editing, and the second one is gene therapy. This second one adds to a healthy hemoglobin gene and to the patient's own stem cells. So it reduces, of course, the symptoms, and to a certain extent, might end up eliminating them. And then the third one is they have disease-modifying medicines or therapy, and they call them immunomodulators. As you can see, Vexelator and of course crisanilizumab, they reduce the pain, and Vexelator improves obviously the hemoglobin levels. And then they have other ongoing trials which are aimed at reducing the swelling at the molecular level. This is something most of you may not have heard of. Yeah, it's there, Lyfgenia. I had a video, but of course I couldn't attach it, but it's quite nice. It is approved, and it's a form of therapy for sickle cell disease that's intended to reduce the frequency, i.e. it stalls the, if you like, relapses, and of course lessens the severity of the typical, as I said, there's 4, and this one is typical of the vaso-occlusive one, not the splenic sequestration, not the aplastic, and not the hemolytic, just that one, vaso-occlusive one. So it is given as a stem cell transplant by one single intravenous infusion and after a round of chemotherapy. So chemotherapy first, and then you have the the Lyfgenia, or Lyfgenia, whatever they call it. And of course, the indications are sickle cell patients between the ages of 12 and older, and with a history of these vaso-occlusive events. The side effects, of course, which would include the sore lip, as it were, soreness of the lip, the mouth, and the throat. You have what they call stomatitis. So it can be angular. Some people may have had it. Just by the angles of the mouth or the lips, you can get that inflammation, which can be painful. They could have developed a fever from that. And of course, the white cells can be low, which then exposes them to infections. So these people have to be really careful. They have to probably have less mingling, less traffic, less crowd where they are, and of course, protect themselves as best they can. Contraindications are, as you can see, none, but the label, if you look at it, includes a boxed warning for the possibility of malignancy arising. I'm not a hematologist, I don't know, but I just go by what is written on the box. Now, obviously, if there are hematologists listening to us, they may well be able to cast some insight as to what it is. But it's a bit like the cigarette box. Not everybody, it's just an analogy, it's crude maybe, not everybody that smokes gets to develop cancer of the lung. Yeah, there has to be other factors, including the smoking, including the nicotine, that can cause that. But if you look at the box, it's clearly written there. Since the days when they paid out billions, they've actually decided to put it on the box. But people still smoke. Now, look, this cigarette can cause cancer. Same as this one. If you look at risk versus benefits, you would have to decide which one. But it is there and you need to know about it. So, prognosis. Well, with modern care, life expectancy is improving significantly. Early diagnosis plus consistent treatment leads to fewer crises and complications. The gene editing therapies may be there to offer functional cures for many people. So how do you prevent it? Well, the carrier testing is absolutely important prior to pregnancy. In fact, prior to getting married, or it's important that genetic counseling for couples, newborn screening very early on is important. And of course, we need to be the champions to raise this community awareness, to reduce the stigma, and of course, address the myth. This is just a healthy diet sheet, if you like, that would help to ward off the possibility of increased crises and live a better life. This is sad. This lady, as it were, black mother with sickle cell, she died, sadly, after gross failure in hospital care. And that was the ruling of the coroner. She said early intervention could have prevented her death if it had occurred early. So, as I said, early recognition, early presentation to the ED, early treatment is absolutely vital. Yeah. However, we question the decision not to issue what we call Regulation 28. This is one that the coroners issue when they think there's a lesson to learn in order to prevent people dying of a similar nature or a similar cause in the future. They issue this Regulation 28, which is known as a PFD. We hate it, we don't like it, but it does happen. And this lady, was a civil servant. She was called Irene, mother of two, and of course, she says, the husband, actually, the eulogy is she's a better place with her in it. The world is obviously a better place with her in it. Of course, he's lost someone very dear to him and the family. And finally, this is it. This is a take home. Now, I don't have time to go through that, but I think it summarizes all what we've talked about already. 1 out of 500 Afro-American or African-American, maybe Caribbean births have sickle cell disease. 1 out of 36,000 Hispanic American births have sickle cell disease, and 1 out of 12 African Americans carry the sickle cell trait. So you can see how big a problem this is and how it is important for us to tackle it. Yeah. So there you go. Share the knowledge like we're doing. That's what we need, taking home. Support the organizations. If you're charitable enough, then yeah, support them. Definitely give blood. And of course, donate if you can. Advocate for equitable care in health. This is what we need. Get tested, please. And of course, it's no longer, i.e. sickle cell, is no longer a silent struggle. It is a condition with real hope, real breakthroughs, and real change is happening now. This is something I'm very proud of. I'm humbled. We as doctors, we get complaints left, right, and center. We don't like them. We think maybe we don't deserve them, but they come. And of course, we do cherish compliments, but they're rare. So this was someone that sent this to me. Maybe you can read. This is somebody who I got in touch with. So it was on Doctors' Day, and they said, I celebrate all the truly exceptional doctors who have been more than just a doctor to me, especially Mr. K. As you can see, life changer, the strength, and a constant reminder that passion still lives in medicine. How powerful is that? Living with sickle cell is not easy, but having you by my side makes the journey a little lighter. Your patience, your dedication, and the way you genuinely care go far beyond prescriptions and hospital visits. You listen, you understand, and you fight with me even on the days I feel like giving up. Thank you for every late check-in, every word of reassurance, and every effort you make to see me, not just as a patient, but as a person. You're truly appreciated today and always. Thank you so much. That's all, folks. Questions, and that's my references.
Thank you so much, Dr. Kamara. And what a powerful ending. It's really lovely to see evidence of a compassionate leader within medicine. So I just want to say thank you. And what a great talk as well. Really informational. We got a lot of information about sickle cell, understanding a bit about how it actually comes about and how people get sickle cell and how it can pass on from generation to generation. So that was very interesting. We have got some questions that we'd like for you to answer. We've got some questions in our chat. And the first question that we've got here is, me and my fiance are carriers. Besides that, we are very healthy and active. How can we plan? We look into IVF, but it's so expensive and NHS doesn't cover, I believe. How early into pregnancy can you test the fetus for sickle cell on the NHS or private? Thank you.
Oh boy, that's a complex question because they're looking at, they know they're carriers, they've got the traits. It's probably better off to get the counseling before you fall pregnant, because once you fall pregnant, the if you like, the trend, or well, no, it's not the trend, the train, if you like, has been started and you're on the journey already. And that is fraught with a lot of complications, as it were. One of them, as you mentioned, you want to find out when, how soon can you do that. Now, normally, they probably will do that in the second trimester, if I'm not mistaken. I don't think they will do it in the first trimester, which is the first 12 weeks, because that's when the fetus is very sensitive and they can react to any kind of intervention, if you like. It's not without reason that in the first 12 weeks, even the pregnant mothers don't want to take anything. They want to be, be involved in any kind of stressful situations, because that's when the miscarriages happen mostly. And so they want to avoid that. So they will do it in the second trimester, which is between the 12th or the 13th and the 24th week. Again, that is fraught with, problems, because there's a risk of miscarriage as it happens. IVF, as you say, of course, is expensive. Yeah, I agree. Again, the IVF is not just the expense of it, it's the fact that you're looking at multiple pregnancies, which are, a problem on their own, as it were, financially, physically, psychologically, and otherwise. Yeah. So, and of course, it's not a straightforward answer, but what I'd suggest is probably there are the agencies there that could be beneficial to counseling, and of course, probably for them to probably guide you the best way forward, really. But I wouldn't want you to fall into the trap of falling pregnant if you can afford it, and then you now have to deal with the other issues which you could have avoided before then. If you see what I'm trying to say, yeah. I always like to look at people, if the expression is allowable, where they stumble rather than where they fell. I always look at the prevention is better than cure. And that's my mantra, and that's what I've always subscribed to. I hope that's helpful.
Yeah, I do have a follow-on question to that. In regarding to get the counselling, how can we go about what's the first step in order to get the counselling?
But I mean, there are agencies there. I don't quite have the addresses. I think there were references in my talk there, which can be accessed. But I'm sure the GPs can help you with that. There's no questions about that, because you're a trainee GP. Obviously, when people come, you probably have this at hand, because that's the best place to go to seek advice. They might refer you to the obstetricians, if you like, or the specialist nurses that would probably guide you as to what. But as I say, there are definitely agencies there that are more specialized in that particular aspect, i.e., sickle cell and wanting to procreate or maybe go and make a baby, if you like, what can be done. As I said, in my slide, you could see they take the blood and then they will send it for the tests. And if there's nothing, then that's that. But if there is, then there are further stages. I mean, I don't know if I can show it to you.
Yeah, sure.
Let's see. Come on now. What has happened?
Yeah, we can see the screen and
I can't even see it. That's the trouble.
Oh, okay.
Here we go. Here we go. There we go. That's the slide.
Okay.
You can see.
Yeah.
You know, prenatal diagnosis, yeah, is important, as it were. The sample obtained is then tested for DNA analysis. But here you are. So before you fall pregnant, it's important. I'd always advise do that before you fall pregnant. And then of course, when you fall pregnant, then of course you then will be offered the screening, which is automatic. They do that. And if there's nothing, then of course do nothing. If there is something, then the result is positive, then they will offer you information and counseling. And then of course they will then offer the screening of the partner, either the male or the female. Well, of course the male, definitely. Although it might be female, but there you go. So the results are positive, then you're offered counseling. And then of course, you get a prenatal diagnosis. So the fetal sampling, blood sampling, and if that is not affecting the fetus or the baby, then no further action required. However, if the fetus is affected, then you probably would need information and counseling. And this is where you have to make your informed choice, either to go ahead, continue the pregnancy with its risks that you may be made aware, or sadly lose the pregnancy.
Okay.
I hope that's helpful.
Yeah, that is a really helpful explanation, running through that again. Also, the Khan team have put in a helpline service into the chat, so anyone can take down those numbers and that email address. So we've got a second question. So why is sickle cell still so overlooked if it's one of the most common genetic conditions here?
Well, again, I think you will continue sharing because the questions are all related. I think I touched on that. I did say that reasons why we're more affected is lack of awareness, funding, which is chronic. There you go. Yeah?
Yeah.
So chronic. And especially now that, you know, the funding has been cut. And of course, the stigma, the myth is attached to that. And of course, with the lack of funding and the lack of awareness, you have delayed diagnoses.
Mm.
And of course, we have unequal access to care. And there's a structural stigma, as we see already, around genetic conditions. However, there's hope in the horizon because the new treatments are changing this, but awareness is key. Now, I don't know whether we can do anything as a group. We can lean on them to actually pay more attention to sickle cell, but definitely it's a global problem. And we're in England, and probably we need to probably escalate this to the powers that be to see what can be done about it, for them to actually pay more attention and give us what we deserve.
Yeah. There's lots of contributive factors into why it's not as known as it should be. Okay.
Yeah, well, that's why one of them is what we're doing. We're actually raising the awareness.
Yeah.
We're empowering people. We're giving them the knowledge. We're sensitizing them, and we're making sure they know about, you know, the treatment that is out there, how available it is, how readily it is available, and how it is we can access it. This is important because some people might just suffer in silence, not knowing. But by doing what we're doing in our own little way, we obviously are empowering our people, galvanizing, you know, the energy to ensure that we're not overlooked, as you're putting it.
Yeah.
Thank you.
We've got another question here. They've asked, is it true that sickle cell is a genetic mutation that gives some protection to malaria?
Yes, I said that.
Yeah. Yeah.
I did say that. That's it.
Yeah.
You see that?
Yeah.
I did say that. As I say, especially the hemoglobin C. Now, that's a topic for another day. Hemoglobin C, obviously, is one of the traits that we talked about. And with hemoglobin C, the knowledge is you are probably, the cell is probably resistant to the plasmodium, which is the source of the malaria. I mean, I can tell you that. I'll talk about myself personally. I only found out that I've got the hemoglobin C when my wife was pregnant with my boy, or our boy. And I was told that that's the case. And so there is the 25% chance of any further pregnancy to see the possibility of a trait, you know, carrier, as it were, in any subsequent pregnancy. But I just reflect back in my days, in my youth in Africa, I was one of the few people who succumbed to malaria. And I saw that just proves the point that, yes, there is some resistance, there is some protection in people who've got that. As I say, every cloud there, it's not that I wish for it, but it is there, you know, the resistance to malaria. Yeah.
Brilliant answer. Yeah. I guess we have another question in terms of being in hospital with sickle cell and having to advocate for yourself with the nurses, the different members of the medical team, the doctors. Is there anything that we should particularly do in order to advocate for certain treatments, making sure that people are aware what sickle cell is? Is there anything that we can do?
Well, I mean, I teach, I present to my colleagues. I've done that nationally, internationally, in conferences, virtually and physically. That is one thing we can do, enrich the knowledge, especially coming from us. We should be, you know, you know, what's the word for it? At the head of the queue in terms of getting people educated, you know, and sensitized. We did that. I think I talked about that, what it needs to be done.
Yeah.
At the very end, I think I did say that it's important to do that. And of course, it's important to have bespoke treatment plans. So if it's there in writing in black and white, and clearly, it's important to pay attention to that as clinicians. So when they come to us in the ED, that's what we do. We need to be seeing these things. We need to be, you know, cutting in. You know, if you look at it, you look at someone and say, oh, this person's a new sickle cell patient, and they come in with pain. Clearly, if you have the knowledge, you know this is a crisis brewing, mainly because of infection. Therefore, you need to get the bloods done, immediately. You need to put a cannula in, and of course, you need to do blood cultures, as it were, and of course, give them the fluids they require plus the painkillers. So in effect, you're bringing them from the waiting room to the majors area where the sicker people are and treating them with the urgency that they deserve. But for that to happen, you have to have the knowledge, you have to have the will, and of course, you have to have the strength of obviously teaching these people who are reluctant to doing that as to what to do or what to expect. See, again, community awareness is important to reduce the stigma. Yeah. And of course, testing is important. There you go. If you see that, sharing the knowledge, advocating for equitable healthcare, and of course, calling everybody to action and getting tested. These are the things that we need to be doing, and I think that would help us.
Thank you. Thank you, Dr. Kamara, for this great and empowering talk. And it's great to just have such an inspirational leader within our community that can give these talks and educate us. And hopefully we'll take it forward as well. So we've come to the end of the talk. I'm going to hand over to Yusuf Amudu.
Right.
I believe Yusuf, my colleagues, just setting up. But meanwhile, I just wanted to say thank you so much, Dr. Kemi and Dr. Kamara, for today. It's been a brilliant talk. Okay, Yusuf is here with us, and I'll pass it on to my colleague.
Yeah, Natasha, can you hear me?
Yes, we can hear you, see you. Everything is great.
Oh, that was a great session. Thank you, Dr. Mohammed Kamara, and thank you, Dr. Kemi Adewumi. And to everyone here for making this session a wonderful and engaging session. We are very grateful for your time, your input in making this a great success. Now, let me share some of the important activities we are currently undertaking within our community as part of our health literacy improvement program. First, the Health Hour session. We hold the Health Hour every Sunday from 11 a.m. to 12:15 p.m. Our dedicated health professionals deliver insightful lectures on a range of health issues affecting Black and ethnic minority groups in UK. It's virtually free and open to everyone. To register, email us at info@can.org.uk. 2. Our African Day event is on the 28th of May 2026 at the University of Salford. This is an event we use to celebrate Africans' progress through diaspora partnership in trade, health, and share growth that we've achieved so far. Entry is virtually free. Also, we have stuff for small fees for businesses to showcase or market their product. If you are interested or you need more information, scan the QR code on the flyer or email us at africanday@can.org.uk. Our next flagship event is the Windrush Day event. This event is scheduled for Saturday, 20th June 2026 at the Alexandra Park, Moorside, Manchester. It is to bring families together to celebrate the legacy and contribution of the Windrush generation contributions to British society. It will be an unforgettable fun day. Entry is free. Come and enjoy yourself. We have live Afro-Caribbean music, cultural performance, and arts. There will be football games, children activities, and lots more. Also, we have free health screening and well talks on the day. We also have store for business owners to showcase their products and services to the public. To book a store, you have to scan the QR code on our flyer or email us at winrushday@can.org.uk. Another event that we are hosting in July 2024 is the Black Tie Gala. It's an award night evening scheduled for 4th July. As I said, it's an elegant evening to honor and celebrate the achievement of Black healthcare professionals and all those in the healthcare space who do outstanding work to keep our communities safe. The evening includes 3 square meals, live music and performance, premium work opportunity, and more. Don't miss out. To get tickets, scan the QR code or email the Black Healthcare Awards at can.org.uk. We also have a program at Can called Can Confidential and Cultural Appropriate Support, which is spearheaded by our Can advocacy team. This team supports people who are in need of housing benefits, housing and benefit applications, or children education support. Anybody who have health concerns and care issues, domestic issues, sexual abuse issues, can get in touch with us to discuss or to have interactions on any issues that bothering them. We offer help in several languages and all interactions are treated as confidential. For further information on these issues, contact our helpline on 077-100-22382 or email at the advocacy team at advocacy@can.org.uk. We also have the Enfield Black Community Forum. This is an office where we provide the community members to connect, speak up, and share valuable experience that helps shape healthcare within our Black community, improve the local services, and enhance access to relevant health information. It is open to the public and it's free to join. For more information, contact us at enfield@can.org.uk. And finally, let's keep encouraging our family and friends to join our weekly health hour sessions. Thank you all for joining us today. We hope to see you all next week. Bye. Natasha, are you there?
Yes, we are here.
Yeah.
Thank you so much, Yusuf. Our colleague Booker will now put the closing video. Or worry not. Thank you. You can stop sharing. Once again, as Yusuf said, thank you all for joining. Thank you, Dr. Kamara. Thank you, Dr. Kemi. Without you, it wouldn't be possible for us to do this work that we do. We look forward to welcome you all on the next Health Hour and all the events that my colleague Yusuf has shared. And yes, we're having a little bit of a difficult technically with the video, but I think it's coming now. And see you next week.
And that's our time for today. Whether you joined us on Zoom, Facebook, LinkedIn, or YouTube, thank you for making the Health Hour part of your Saturday. We hope today's session gave you the right dose of health wisdom that you can share with your friends and family. When we share knowledge, we strengthen our entire community. Mark your calendar. Next Saturday, same time. Got a topic in mind? We want to hear from you at health@can.org.uk. Health Hour. hosted by the Caribbean and African Health Network.